All, this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. Today we are meeting a little earlier. We have a superstar with us. We have a rock star with us of medicine, Dr. Paul Marik. So what we'll do is this. Let me quickly introduce Dr. Paul Marik for those who are new. For the cool beans who've already been here, they know that we have our king bean over here. So here is Dr. Paul Marik's introduction. So I am actually reading it from his site. So let me actually show you his introduction as well, so you can feel free to read it as well. So here, this is the profile of Dr. Paul Marik, Professor of Internal Medicine. Dr. Marik received his medical degree from the University of Witwatersrand, Johannesburg, South Africa. He was an ICU attending at Baragwanath Hospital in Soweto, South Africa. During this time, he obtained a Master of Medicine degree, Bachelor of Science. Think about the overachievements that our rockstar has over here. A Bachelor of Science degree in Pharmacology, Diploma in Anesthesia, as well as Diploma in Tropical Medicine and Hygiene. Dr. Marik did a critical care fellowship in London, Ontario, Canada, during which time he was admitted as a fellow to the Royal College of Physicians and Surgeons, Canada. Dr. Marik has worked in various teaching hospitals in the US since 1992. He is board certified in internal medicine, critical care medicine, neurocritical care, and nutritional science. Dr. Marik is currently Professor of Medicine and Chief of Pulmonary and Critical Care Medicine, Eastern Virginia Medical School in Norfolk, Virginia. Dr. Marik has written over 400 peer-reviewed journal articles, 50 book chapters, and authored 4 critical care books. So this is Dr. Marik's and his colleagues' Frontline COVID-19 Critical Care Alliance. This is where they have their proposed schedules, iMask Plus, iMath Plus, for management of COVID-19 and for the usage of Ivermectin. And here is, I want to put this up front so that you are not thinking that we are not aware of the NIH's stance. So here is an NIH, and they generally are not against or pro anymore, which is a good news, but they're not fully convinced as well. And here are their laundry list of thinkings that they think why ivermectin may not be ready. I actually think that this is slightly unjustified, but we'll have Dr. Marik talk about it as well. And finally, this is the Twitter thread where we have hundreds of questions already. I think we would have to sit here for the whole day to continue to answer them. So we'll try to answer as many as we can. So with this introduction, I am now going to bring us to the presentation. So Dr. Marik, all yours.
Thank you, King Bean. We can move to the next slide. So welcome everybody. So the plan is I'm going to give a talk for about 30 minutes, and then we'll have 30 minutes for questions, and hopefully I can give some logical answers. So I'm going to start off with a treatment overview. I'm then going to talk about ivermectin, progress or not. And I thought it's important just to talk a little bit about vitamin D and what about melatonin. Okay. Next slide. So this slide summarizes what we know. So this is a summation of randomized controlled trials looking at the most commonly used medications for SARS-CoV-2, divided into pre-exposure, post-exposure, the symptomatic phase, and the pulmonary phase, because clearly treatment is phase specific. Going down the list, hydroxychloroquine, we can see really of unclear benefit. Remdesivir, in terms of symptomatic phase, no benefit. What it does, has been shown, is it reduces time to recovery in the very early pulmonary phase, has no mortality benefit. The HIV proteases, no benefit. Interferon may be of benefit early, harmful later. Tocilizumab, really of unclear benefit in the pulmonary phase. Convalescent serum and monoclonal antibodies, these have failed. There's really no data that either of these work, and the monoclonal antibodies actually were harmful in the hospital phase. Corticosteroids, to be clear, they are of benefit in the pulmonary phase, tend to harm in the symptomatic phase. And what is truly remarkable is ivermectin. So as you will see, ivermectin is of benefit in the pre-exposure, post-exposure phase, the symptomatic phase, and the pulmonary phase. And this table is based on the evidence from randomized controlled trials. Next slide. So this slide just puts everything together. As we know, the treatment of SARS-CoV-2 or COVID is very much phase specific. We have the incubation period, the symptomatic phase, the early pulmonary phase, and the late pulmonary phase. And what is really critical to understand is that the treatment is phase specific. So antiviral therapy will actually only work when you have viral replication, i.e. early. In the pulmonary and late pulmonary phase, the virus is dead. You cannot kill something which is already dead. So the use of antiviral therapy in the later phases makes really no sense. So we use a methylprednisolone in the pulmonary phase. In terms of anticoagulation, the data is quite clear that anticoagulation in hospitalized patients reduces mortality. And then ivermectin spans the course as we saw before, and then melatonin, vitamin D, vitamin C, flavonoid, and zinc. So this is a summation of our phase-specific treatment approach. Next slide. So this is what the NIH has to say about the issue. So in non-hospitalized patients, they don't make any recommendations. If you hospitalize and don't require oxygen, they don't treat you. So you're basically not being treated. If you hospitalize and require supplemental oxygen, they recommend remdesivir plus dexamethasone. If you require more oxygen, you require dexamethasone. So this is really all the NIH has to say in terms of treatment of SARS-CoV-2. Next. Going on, ivermectin, as we'll see, they say there's insufficient data to recommend either for or against, which makes no sense. Convalescent serum, which we know there's no data. There's no data to support the use of convalescent plasma. They say there's insufficient data to recommend either for or against, which is astonishing. Vitamin C and vitamin D, again, insufficient data to recommend either for or against. We'll cover some of these recommendations. Next. In terms of prevention and prophylaxis, they actually have nothing to say. They do not recommend treatment for early SARS-CoV-2 or for prophylaxis of SARS-CoV-2. Next slide. So this really is the problem. This is, we're confronted with patients who contact us and email us every day. The story is the same. My doctor told me there was absolutely nothing she could prescribe for me, and if my lips turned blue or I could not breathe, to go to an emergency room. This is truly astonishing in our country, that patients who have SARS-CoV-2, who are sick at home, the treatment is nothing. You stay at home and you stay there until you get blue and you have pulmonary involvement. It's an absolute outrage because, as we know, there are effective early treatment. But this appears to be what the standard of care is, which obviously we find intolerable. Next slide. So because of this, we came up with the IMAS protocol. So the MAF protocol really is for the pulmonary late treatment phase. But it became clear that to control this pandemic, we need to prevent the disease with pre and post-exposure prophylaxis and treat people early. People who are symptomatic, we need to treat them early. And the reason is obvious. Firstly, if you treat them early, you prevent progression to the pulmonary phase. These people don't need to go to hospital, they don't need to get sick, and they don't need to die. So this will enormously relieve the terrible resource problem in the hospital. Secondly, if you treat these people, you will rapidly decrease viral shedding. So these people will become less infectious, so they will not spread the infection. So for both these reasons, it's essential that people who have COVID early should be treated. Next slide.
And Dr. Marik, can I actually add that if we have treated people early, them becoming long haulers would also become a lesser of a chance?
Absolutely. If you treat them early, this is just common sense. We know this in medicine is no disease benefits from a delay in treatment. So if you treat them early, they are much more not likely to progress. They're less likely to develop all the long-term complications of COVID because you treat them early, you prevent disease progression. So there's absolutely no question of doubt that you want to treat them early just to prevent the short and long-term complications of this disease. So this is the IMAS protocol. So it has two pieces, the prophylaxis protocol and the early outpatient treatment. So in terms of ivermectin for prophylaxis, so this is for high-risk individuals. So these are people in long-term care facilities, healthcare workers, people who are at high risk. So we recommend 0.2 milligrams per kilogram, one dose today, and then the second dose after 48 hours, and then to dose every 2 weeks, and we'll talk about it.
Dr. Marik, is that, so 0.2 milligram or 200 microgram, correct?
So it's 0.2, or 200 micrograms. So it works out about 12 milligram dose if you're about 70, or if you're over 70, about 15 milligrams. And you take it all at once. So it's 12 milligrams day one, 12 milligrams in 48 hours. You don't divide it. And then 12 milligrams every 2 weeks. So the usual dose is about 12 milligrams. If you weigh more closer to 80 kilograms, and maybe 15 milligrams. It comes in 3 milligram tablets. So that's why we talk about 12 milligrams, 15 milligrams, or 18 milligrams. And some people get confused. You take, if it's 12 milligrams, you take all the tablets at the same time. You don't spread them out. And then we include vitamin D, vitamin C, quercetin, zinc, and melatonin. And we'll talk about some of these things. For early outpatient treatment, it's a similar protocol. So it's 0.2 milligrams per kilogram daily. So day one, day two, and then you can continue for up to 5 days. And it's again, about 12 milligrams on day one, then day two. So you need to take a minimum of 2 days. It's important. We do not recommend single day treatment. So take at least for 2 days. Many patients after 2 days feel remarkably better, and it's okay to stop at that time. If they still have ongoing symptoms, to continue for up to 5 days. And then vitamin D, vitamin C, quercetin, zinc, melatonin, and we add aspirin. So that's the prophylaxis and the early treatment protocol. Next. So we need to talk a little bit about ivermectin. And as I will show you, this is no longer a medical issue. I think the data is overwhelming. Put bluntly, there's no medication that has been proven to be more effective for the treatment of SARS-CoV-2 than ivermectin. Maybe I should say that again. There's no medication that has been proven to be more effective than ivermectin for the treatment of SARS-CoV-2. This is based on 40 clinical trials involving 288 scientists and 14,000 patients. So people who don't believe this data, they have to infer that all these 288 scientists are fabricating this data. This includes 20 randomized controlled trials. There's no other medication for SARS-CoV-2 that has more randomized controlled trials, which is the gold standard that the ivory tower is requesting. So there's an 89% improvement in prophylactic studies, 81% improvement in early treatment, 78% improvement in the mortality studies. If you look at the risk reduction, it's remarkably low. The studies show that ivermectin across the board is highly effective. If we were to adopt ivermectin today across the world, we could save 60,000 lives per week. So I don't think this is any more a medical or scientific question. I think the data is quite clear-cut. It unfortunately has become a political question because I think the science is quite clear. Next slide. So what I'm going to do is present some data from Dr. Andrew Hill, who's been contracted. He works at the University of Liverpool. He's been contracted by the WHO to look at all the data related to SARS-CoV, to ivermectin. He has a full team of researchers, and they're working on this day and night. So this is data which is about 2 to 3 weeks old, which he made publicly available. Obviously, every day we have new data, so the data is significantly stronger than it was when he presented this. Next slide. So you can see at that time, 18 randomized controlled trials. So the WHO are only interested in randomized controlled trials. So you can see 18 trials with over 2,000 patients across a spectrum of countries. Next. So this is the data looking at 9 randomized controlled trials using day 1 dosing. So you can see the way these studies are designed. They compare ivermectin versus ivermectin it's standard of care versus ivermectin. So these are randomized studies in which they randomize patients to standard of care or standard of care plus ivermectin. These 9 studies used single daily dosing. Next. There are another 9 studies, again, comparing standard of care versus ivermectin. You can see that they used multiple day dosing, usually up to 5 days. So this becomes an important question of single day or multi-day dosing, as you'll see. Next slide. So when we look at mortality, survival benefit, the studies that looked at mortality as an endpoint, you can see the mortality with ivermectin 2.3% versus 10%. Next slide. So when you look at this in a meta-analysis with observational studies at the top and randomized studies, for those of you who are not familiar with the way a meta-analysis works, basically what you do is if the data is so this is the point prevalence, if it's to the left of the axis of 1, it means that it favors the treatment or ivermectin. If it crosses over the line of 1 or unity, it means that it's neither beneficial or harmful. If it's to the right of the 1, then it means that it's beneficial, the control, that it's harmful or not beneficial. So you can see that for the observational studies and randomized controlled trials, that ivermectin is highly efficient in reducing mortality. So this is all-cause mortality. You can see the risk reduction is 0.25. So that is a profound reduction in the risk of dying. So that this meta-analysis demonstrates that if you combine all these studies, significant mortality reduction. What's important to note is that consistency of effect. So when there's some questions about the validity of the studies or the data, the treatment effect usually varies quite significantly. You can see in this meta-analysis, the treatment effect really lines up very closely, which signifies that this is a reproducible and consistent finding. Next. So when we look at viral clearance, again, this is a meta-analysis looking at time to viral clearance. If it's on the right of 1, it favors ivermectin. And you can see it looked at multi-day and single day, and you can see a significant improvement in viral clearance. What's important is this is an objective finding. So people have argued that the studies were not blinded, or that wasn't strictly controlled, that there was some subjective bias. Viral clearance is an objective finding, unlike symptoms. So this is a real finding. Next slide. This is time to clinical recovery. Again, on the left now, favoring ivermectin. You could argue that time to clinical recovery is more subjective, but nevertheless, it again all lines up very clearly to the same side. Next slide. When we look at prophylaxis, you can see how profoundly effective ivermectin is for prophylaxis, and this includes observational studies and randomized controlled trials. Highly effective in prophylaxis, and you can see again what's truly remarkable is the consistency of the effect. The treatment effects are all very similar and line up very closely, making it highly likely that this is a real finding. Next slide. So this is a very important study to look at. You know, the NIH and WHO are so focused on randomized controlled trials. But what we also need to do is look at real world experience. So there have been a number of provinces and states across the world where there have been mass distribution programs of ivermectin. So this was done in Uttar Pradesh in India, a population of 210 million. And you can see starting August the 22nd, they started a mass distribution of ivermectin. Very shortly thereafter, you can see there was a rapid decrease in both cases and mortality from SARS-CoV-2. However, the most impressive part of the study is that they did Google mobility studies to look at movement of people. So you can see as the mortality was falling and the cases were falling, there was greater mobility to workplace. People were going to parks, people were going to retail stores, and people were going to the grocery. So as there was this mass distribution program, and the cases and mortality fell, concurrently the economy opened up again. People's lives went back to normal. They started going to the park, they started doing recreational activities and going to the store. And this is exactly the goal which you want to achieve. So they were able to, within a very short period of time, with mass distribution of ivermectin, basically reduce the case counts, reduce the mortality, and open up their economy. Next slide. So what about the safety? So, you know, ivermectin has been used for close to 30 years. And this is a study which looked at the clinical experience and safety and basically came to the conclusion that they're negligible adverse effects. It has a very robust safety profile. It can be used in children as young as 6 months of age. Most of the reactions are due to the death of the parasite rather than the drug itself. So it's an allergic reaction due to the death of the parasite. It's not recommended in pregnancy because particularly in the first trimester of pregnancy, there is a possibility of teratogenesis. So it's not recommended in pregnancy. But obviously, you know, if a woman is pregnant, there would be a discussion she would need to have with her physician, weigh the risks and benefits. But generally, it's preferred not to be used in pregnancy. The only problem really is there are a number of drug-drug interactions, so that particularly with drugs which are used for transplant. So if patients are taking a host of medications, they should check on the drug-drug interactions. Next slide. So this, I think, is a very important slide. So this is a slide from the World Health Organization, the VG-Access database. This is the pharmacovigilance reporting database. They basically look at all reported deaths and adverse effects. And as you can see, this was dated yesterday. So for ivermectin, in the last 30 years, there have been 16 reported deaths, and I should say this is an association. So there's an association between the medication and death. It's not a confirmed, it's a suspected association, and 4,000 adverse events. If you look at remdesivir, which has been used for less than a year, 412 deaths. If you look at COVID-19 vaccines, which we've had for about 2 months, 922 deaths already and 84,000 adverse events. So what the slide shows is that this is a drug which has been used for over 30 years and is remarkably safe. It's remarkably safe when compared to all the other medications used for the treatment of COVID-19. Next slide. So, on January the 5th, we went to the NIH and we pleaded with them to change their recommendation, which was a 3B against for reasons that are unclear. They then changed it to cannot advise for or against. Again, on the February the 11th, which is like 5 or 6 days ago, they came up again with a revision, which again says there's insufficient data for COVID for their panel to recommend either for or against ivermectin. Results from adequately powered, well-designed, and well-conducted clinical trials need to provide more evidence-based guidance. So as I said, we already have 20 randomized controlled trials from across the world, and it provides real-world experience. What more do you need? They focus on 2 points. The first one, in order to downgrade ivermectin, is they say ivermectin has been shown to inhibit replication in cell culture. However, pharmacokinetic and pharmacokinetic dynamic studies suggest that achieving the plasma concentration necessary for the antiviral efficacy detected in vitro would require administration of doses 100 times those required for humans. So this is completely false. It's completely false, and we explained this to them in some detail because the statement is not true, but they continue to perpetuate this falsehood, which I will explain in more detail. So they know this is true, but they continue to perpetuate this lie. Secondly, they say some clinical studies showed no benefit or worsening of the disease. There's one study, if you can call it a study, which I'll talk about, which so-called showed worsening, which we'll talk about. Okay, so next slide. So this was the famous study by Dr. Kelly and Wagstaff, which really brought ivermectin to our attention, showing that ivermectin reduces replication of SARS-CoV-2, and they went through one of the proposed mechanisms, which was binding to the alpha-beta important. Next slide. This is the IC50, which was about 2 micromolar, which is quite high. However, this was done in monkey kidney cells. This was done in monkey kidney cells. Just remember, we do not treat monkey kidney cells, we treat patients. Monkey kidney cells lack an immune response. They do not make interferon. First point. Secondly, the concentration in the lung is significantly higher than that in the serum. Ivermectin accumulates in the lungs and in fatty tissue, reaching much higher concentrations than in the serum. Additionally, they looked at short-term exposure, whereas when you take a medication, you have a much longer effect with repeated doses. And when you actually look at human lung cells, so they repeated this experiment not using monkey kidney cells, but using human lung cells, and showed the IC50 was significantly lower. The next slide. So this is the pharmacology. So a 200 microgram per kilogram dose will reach a Tmax of about 60. If you take it with a meal, it's about 150. The concentration in the lung is at least 3 times, which is 180 to 450. If you look at the IC50 for alveolar cells, it's now 0.4. So the IC50, not for monkey kidney cells. Who in the heck is interested in a monkey kidney cell? We're interested in human alveolar cells. And you can see the IC50 is significantly lower, and the level is far exceeded. The lung levels far exceed that which you achieve with the IC50. So this obsession the NIH has of continuing to perpetuate this falsehood. It's a falsehood. They know it, we know it, but they continue to perpetuate this falsehood. So this must stop, because we know that if you look at this revised data, this rationale not to use ivermectin based on this pharmacokinetic principle is clearly wrong. Next slide. They then quote this so-called study as a study called Causing Harm. So they ignore the 20 randomized controlled trials which have shown a benefit, but yet focus on this cohort study. And what they did was they looked at all patients in Peru who had SARS-CoV-2. They then looked at what medications they received: hydroxychloroquine, ivermectin, azithromycin. And what they found is that the patients who got ivermectin had a higher mortality than those who received standard of care. Now, they looked at all patients regardless of severity of illness. And it's kind of obvious that the sicker patients are going to receive medications as opposed to those who are mildly symptomatic or not symptomatic at all. Next slide. So looking at the slide in more detail, basically they show that all of the medications, it doesn't matter which one you received, had a higher mortality, consistent with the concept that symptomatic or mildly symptomatic patients were in the control group. So the control group were people who were mildly ill. The study does not compare control groups. So normally when you would do a observational study, you would have an equally matched control group. This study does not have a control group. The excess mortality happened on the first day. This is consistent with patients being treated who had more serious disease. However, the authors of the paper state that patients who died within 24 hours were excluded, but they never excluded them. If you then compare ivermectin versus standard of care patients, they were significantly older, more male, had significantly marked comorbidities, and there was marked geographic variation. And most importantly, there was no index of disease severity. So they were comparing apples with tangerines or apples with grapes. There were two completely different groups of patients. And it really is scientifically unsound to make any kind of inference from this really poor study. However, the NIH focuses on this study, which clearly has significant limitations, and not the 20 randomized controlled trials that are already being done. So you can see the enormous prejudice that the NIH has in their interpretation of the data. Next slide. So, unfortunately, they're being dishonest, and dishonesty has serious consequences. Next slide. So, despite all of this, what actually has happened with the use of ivermectin? So this is a really interesting study recently published in JAMA, which looks at outpatient dispensing for a number of repurposed drugs. And you can see that the increase in prescriptions from baseline for ivermectin was close to 600%, greater than any other medication. So despite the pushback or the lack of recommendations the NIH makes, there are clinicians in this country who recognize the benefit of ivermectin and are prescribing ivermectin. Next slide. And this study actually looks at the number of prescriptions for ivermectin. And you can see starting towards the middle of October, it starts to spike, which is kind of interesting because our first YouTube video was on the 24th of October. And towards the 30th of October, we started with our eye mask protocol. So you can see simultaneously with us popularizing and making people aware of the use of ivermectin, there's been an exponential increase in its use, and we hope it continues to increase. Next slide. So again, this is the IMAS protocol. Ivermectin, we've discussed at some length, but it includes vitamin D, vitamin C, quercetin, zinc, and melatonin. And I'll briefly cover a few of these. Next. So just to talk about ivermectin, this is a distribution policy for mass distribution of ivermectin to treat onchocerciasis. It's the 2-2-2 rule. I added another 2. So it's 200 mics per kilo per day, which is 2 tablets per day, 6 milligrams for 2 days. So basically, in terms of population distribution, it's 2 tablets a day for 2 days. I added a second 2, which is, it costs the WHO, we understand, 2 cents a tablet. 2 cents. So you can understand why remdesivir is being pushed, which costs $3,000 a course and has minimal benefit, yet we have a therapy which costs 2 cents, which the NIH and WHO are ignoring. I think the conclusions are and inferences are pretty clear-cut. Next slide. So in terms of our prophylactic supplements, vitamin D, C, quercetin, zinc, and melatonin. Next. So I'm going to cover just a few of them. This is from what Dr. Fauci said. So this is a news report. So Dr. Fauci says, I would not mind recommending vitamin C. I do take it myself. So although the NIH cannot recommend for or against vitamin D, Dr. Fauci himself takes vitamin D. And in addition, Dr. Fauci says he takes vitamin C. Again, the NIH cannot make a recommendation for or against vitamin C, and yet Dr. Fauci himself, who knows better, takes vitamin C and vitamin D. Next. So I think vitamin D is important because particularly in winter, particularly those people of color, particularly obese people, particularly elderly people, particularly people in the north, you're at higher risk of vitamin D deficiency. And we know that as your vitamin D levels fall, your risk of developing COVID go up. Next slide. We know that people who die of COVID have much lower levels of vitamin D than those who survive. Next slide. So this is a study, this is actually a systematic review and meta-analysis of vitamin D deficiency. And the summary is vitamin D insufficiency increases hospitalization and mortality from COVID-19. So this is not a difficult concept to understand. Vitamin D has really important immunological properties. It's important for T cell function. It mitigates the cytokine storm. And we know that people who are vitamin D deficient are at higher risk. These are elderly people, people of color, obese people. So why in the heck are we not supplementing these people with vitamin D? It's such a cheap and effective intervention. Next slide. This is a study which was published just a few days ago looking at the use of calcifediol in patients admitted to hospital with SARS-CoV-2. So calcifediol is 25 hydroxy vitamin D, so it's a more active form, so it acts much more quickly and it achieves levels much quicker. So this was a cluster randomized trial, 550 patients randomized to calcifediol and 379 controls. What did they find in terms of ICU admission? Those who were treated with the vitamin D, 5.4% versus 21% in controls, showing a dramatic reduction in ICU admission if you gave 25 hydroxy vitamin D. And again, you can see a reduction in mortality, 6% versus 15%. It remains mysterious to me why we do not promote the widespread use of vitamin D. It's safe and it appears to be very effective for both preventing and treating SARS-CoV-2. Next slide. So this is the Kaplan-Meier survival curve from that study. You can see dramatic reduction in mortality with calcifediol. Next slide. So we're next going to talk about melatonin. So this is a bat. As we know, bats are the natural reservoir of coronaviruses. They harbor a whole host of coronaviruses, yet do not become symptomatic. One of the astonishing facts is that because they are nocturnal animals, bats have the highest concentration of melatonin of any other species on this planet. If you block their melatonin synthesis, they become symptomatic. So this provides a very interesting rationale why melatonin should actually work. Next slide. So melatonin actually, it's not just a molecule which makes you sleep. It has remarkable properties. It's probably one of the most potent antioxidant, and it neutralizes a whole host of reactive oxygen and reactive nitrogen species. In addition, it has an extensive list of physiological properties. It's highly anti-inflammatory, which is really important in SARS-CoV-2. And what it does, interestingly enough, increases ACE2 expression, which has a protective effect with SARS-CoV-2. So that's just a general summary. Next slide. What's very interesting about melatonin specifically is a mitochondrial antioxidant. And we know that mitochondria are the energy source of the body. All one's energy is made in the mitochondria. If the mitochondria suffers oxidant damage, you get impairment of energy production. So there are specific melatonin receptors on the mitochondrion, the M1 and M2. But what is quite intriguing is mitochondrion actually can synthesize melatonin. And melatonin protects the mitochondrion from oxidative injury and is essential for the electron transport chain. Next slide. So one of the problems with SARS-CoV-2 is it switches off aerobic metabolism, switching to anaerobic glycolysis, so that the cell is more dependent on glucose rather than entering the Krebs cycle. One of the consequences of this is that the mitochondrion cannot produce melatonin. So it becomes a vicious cycle that deficiency of melatonin promotes anaerobic metabolism, which indeed at the same time decreases melatonin production. So supplementing melatonin tends to reverse this change in energy utilization by mitochondria. Next slide. So the question is there any data that melatonin is of any benefit? Well, this was a study from Cleveland Clinic looking at risk factors for getting SARS-CoV-2. The most potentially impactful is the reduced risk of testing positive were patients on melatonin. So if you were taking melatonin, you had a significantly lower risk of developing SARS-CoV-2. Next slide. This happens to be a randomized double-blind study in patients who were given. So these were hospitalized patients treated with melatonin. You can see it was a small randomized trial. These people weren't that sick, but there was a significant reduction in hospital stay and in time to discharge. So again, in the small study showing time to discharge and return to baseline health, significantly better in the patients who received melatonin. Next slide. So finally, there's the study out of New York, which looked at mortality in patients who intubated. So these are people in the ICU, and they found that if you're receiving melatonin, your hazard risk was 0.13. So there was a 90% risk of dying, a 90% risk of dying if you got melatonin. The p-value was there were so many zeros that they had to put it in exponential form. That's how highly significant it was. So again, here we have a molecule which is very cheap, very safe. It's probably one of the safest medications that will both reduce your risk of getting COVID and of dying of COVID. And it's troublesome that this drug is not promoted more widely. Next slide. So, how to control the pandemic? So, just to summarize some of the things I've said today, we need to inform and educate the public. We need to provide the truth. We need public health measures, mass social distancing testing. We need prophylaxis in high-risk groups, and we need to prophylax vitamin D, melatonin, vitamin C, and ivermectin in high-risk groups. Early treatment at home for symptomatic patients, really important to prevent progression of disease, to prevent the long haulers. And then finally, for those people who actually miss out on the earlier steps, those who arrive in hospital, we want to treat them with the MATH protocol early. This is not to say that vaccination doesn't have a role. Vaccination is important, but it's not the entire solution. It's going to take months, if not years, to vaccinate the entire population. And then we have the problem or the potential problem of mutant species, which may be less susceptible. So I think this is part of the overall package. So with that, thank you. Next slide, and I will take any questions.
So thank you very much. This is one of the best talks. So let me actually bring up the questions as well that are being asked. And so there are, Dr. Marik, we are at 4:50. I know that we wanted to wrap it in about an hour. There are two ways we can go about this. One is we can ask some main themes instead of individual questions, or answer some main themes and then maybe meet again a week later, 2 weeks later, just for the questions part, whichever way.
Yeah, well, we can do questions for about 20 minutes, and then we could certainly meet again in 2 weeks and answer any remaining questions. And if you want to kind of group them, that's fine. I'll be happy to answer.
So let me do this. The cool beans that are live here, first of all, questions, and then thank you. There is, Dr. Marik is a legend. So we love you. That is the baseline of all of this. So let me do this. Why not I go over some of the, so first question here, which I saw, So let's start from here. This is a very common theme. Your thoughts on ivermectin for long haulers?
Yeah, so, the long hauler syndrome is something we don't really understand well. I think that it presents in many different ways. Fatigue, tiredness, malaise, muscle pains, chest pain. But there are also people who have, autoimmune diseases. It's a spectrum. So in terms of the tiredness, the malaise, the headache, the just not functioning well, there is one study that used ivermectin, 2 doses, and if necessary, repeated that showed a benefit. In addition, I think that there's a place for people to take omega-3 fatty acids, because I think omega-3s are really important for inflammation resolution. I think also there's a role to continue vitamin D and vitamin C. So, it's a disorder we don't have really many good answers. I think good nutrition is really important, particularly people who've been left hospital, that they want to make sure they take a nutritional supplement. And if they are having severe long hauler symptoms, I think it's worthwhile trying, a 2-day course of ivermectin.
Got it. Thank you. So let's do this, cool beans. If you give me 1 minute, I'm going to go over some of the bigger themes on the Twitter side, and then we'll come back here. So one bigger theme here that I'm seeing is folks asking that how many places have been using ivermectin. My experience is that individual doctors, private clinics are using it more often than the larger organizations. What is your observation?
Yeah, I think that's absolutely true. I think there are lots of private practitioners and smaller clinics that are using it. I think that many of the major hospital systems have not really adopted it aggressively yet. But I think as this, the study shows that the outpatient use is increasing. So I think with time, hopefully more and more practitioners will be using ivermectin. I think most of the ivermectin use is, by private practitioners rather than large healthcare systems.
Got it. And I'm going to lump these two questions together as well from Jonathan and from Brooks. And that again is, have you observed someone using it, hospital or private clinic, and have you seen positive results? And I think that is a discussion we did. Any comments you want to add?
Yeah, so it's truly astonishing the response we get from patients. These people who are at home, they really feel terrible, have fever, rigors, malaise, and the story is very consistent. Within 24 to 48 hours, they tell us they feel like a new person. They feel that they've been cured, that the change is so dramatic. So it seems that these people respond to the ivermectin very quickly. Within 24 to 48 hours, they turn around very quickly. And that seems to be a consistent theme from patients who give us feedback.
That is my observation as well. So one more thing, Cool Beans, I'm going to skip over the questions that are not related to ivermectin, vitamin D type things. Secondly, I'm going to skip over the questions that are more organizational and political. I want to make sure that this talk becomes a gift that you can share with others and it can save lives. So I want to just keep it focused on ivermectin, vitamin D, and C, and melatonin. Here is one more question that has been asked many times by Joe Smith, and that is, high-risk patients, if they were using, let's say, ivermectin or IMAS plus protocol, should they, after the vaccine, continue to use it? This is a very common question.
Yeah, so that's a good question. So firstly, after the first dose, you only have about 50% protection. Your protection goes up to 90% about 2 weeks after the second dose. So people who've had the first dose should continue to take ivermectin until at least 2 weeks after the second dose. Furthermore, if you consider yourself at really high risk, so you may be in a healthcare environment, or you're traveling, or you're in an environment where you think you're at high risk, I think there's nothing to lose to continue to take ivermectin. So I think that's a personal decision you need to make. Certainly, you can take ivermectin and be vaccinated at the same time. There's no interaction between them. So, for example, I have been vaccinated. I recently traveled and I took 12 milligrams of ivermectin before I traveled, just to give myself that additional level of security. So I think if you've been vaccinated and you think you're in a high-risk situation, certainly there's no downside to taking ivermectin when you feel you're at high risk.
Excellent. So these are actually a couple of questions that were up in the Twitter thread as well. One more question here. What we'll do is this, one more question or maybe two here from Twitter, and then we'll go to the live side. So one question here, which is very common, is that if somebody becomes dizzy after taking ivermectin, is that some indicator that this may be crossing the blood-brain barrier? Should they stop it or reduce the dose? What should they do?
Yeah, so you know what? It seems to be not a common problem. So I would continue. This idea of alteration of the blood-brain barrier, I think, has been overplayed. I think it's a very safe drug. Sometimes patients will have a little bit of dizziness or headache. It usually passes really quickly. So I would continue.
Got it. Thank you very much for that. Dana Parrish, so she and Dr. Phillips has written this book, Chronic. We had Dr. Phillips with us here in our show as well. So Dana Parrish, she's his co-author. So she said, please tell Dr. Marik that Dr. Steve Phillips and she are sending warmest wishes of appreciation and support, and to Dr. Drbeen as well.
Thank you.
So these are primarily some of the main themes here. My apologies to the Twitter folks that I'm going to go and I'm going to try to get some of the questions from the live side as well. So I'm going to stop sharing and bring in questions from the live talks here. Okay, so Alexander Vasara. So his background, he's a doctor. He is a friend of mine as well. Dr. Vasara says the excuse for not using hydroxychloroquine was a QT prolongation, and now for ivermectin, it will be the BBB, question mark. So I think he's being facetious.
Yeah, you know what? I think people are going to find whatever excuse they can. I think, if you're a collie dog or a tortoise, then maybe you would be interested in your blood-brain barrier. But for most humans, it's completely irrelevant. So I think it's not an issue.
So this is a Bob's question here. I'm curious if Dr. Marik has any opinion regarding the proposal by Belgian virologist Mark to use ivermectin to eradicate SARS-CoV-2 within 6 weeks.
Yeah, so I think, that they demonstrated this in India. If you have a mass distribution of ivermectin, you distribute it to the entire population, you can effectively get rid of SARS-CoV-2. So yes, I think it's possible.
Got it. So this next question is interesting, and here is a difference. When I prescribe ivermectin to my patients, I give it weekly, and iMask is bi-weekly. So Jim is a very cool bean. His question is bi-weekly or weekly?
Yeah, so that's a good question, and so
totally open. Your choice, whatever you want to say, I'll be fine.
So I think both approaches is fine. What we know is that Carvalho in Argentina used weekly dosing, and then he stopped after 10 weeks. We know that in India they did monthly dosing. So with weekly, the infection rate was close to zero. With monthly, it was about 6 or 7%. We think with every 2 weeks or bi-weekly maybe is a compromise in terms of just practicality. What does happen is ivermectin gets stored within the fat tissue in the lung tissue and can be detectable for up to about 17 days. So we think that twice weekly probably gives you as much protection as weekly. But if you want to take it weekly, I think that's fine. There are still ongoing studies as to the optimal dosing interval. I wouldn't extend it beyond 2 weeks because then I think your risk of infection goes up. So, it is a very safe drug. So I think it's just a balance between convenience and practicality.
Got it. Thank you. Tommy, does ivermectin have the same protection against all of the variants? Very common question.
Yeah, so that's a really important question. So based on its mechanisms of action, we would predict and anticipate that ivermectin would work against all the different variants of coronavirus. It's a broad spectrum antiviral. Because of its mode of action, it would seem to be enormously unlikely, if not vanishingly impossible, that coronavirus would develop resistance to ivermectin. So I think that's one of the really important points to bear in mind when one talks about the global problem.
Got it. Nancy says, does the liver need some protection like milk thistle when taking ivermectin?
Yeah, so I'm not sure where this liver issue comes from. The FDA warns against hepatitis. We found one reported case in the whole world literature of hepatitis. So just to reiterate, 3.7 billion doses of ivermectin have been distributed, which is almost half the world's population. And we're aware of one case of possible hepatitis. So this issue of the liver is complete bogus.
Got it. Thank you. Golmuk says, do you think that the WHO will approve ivermectin in the next 4 to 6 weeks?
Yes, well, Dr. Hill is working on this, and we would be hopeful that in 4 weeks' time that there would be sufficient evidence for the WHO, that it would have crossed the threshold that they would consider that there's sufficient evidence. So we're hopeful that within 4 to 6 weeks there'll be sufficient data available for the WHO to make a recommendation to use ivermectin.
Got it. Jana Taylor says taking ivermectin for long COVID. So she has long COVID or post-COVID syndrome, and just discovered I have COVID, waiting on insurance to start treatment for my CVID. Sorry. Should I continue my ivermectin?
Yes, I don't see that it should be a problem. I would just check the drug-drug interactions with other possible medications that she's taking. So, her physician can do a drug-drug interaction screen, which I think is important. But I can't see a reason not to take it.
Got it. One more question. It skipped my mind. It'll come back to me. There is an unrelated but a good question from Patricia here. Is your sepsis protocol gaining ground in the city's hospitals? I like this question.
Yeah, you know what? It's just such a difficult question. You either believe in it or you don't believe in it. It's like you believe in the tooth fairy or you don't. So, we still believe in our sepsis protocol. People are still using it. People are studying it. I think it needs to be refined. But yes, I think it works.
Excellent. Thank you. So, Jana, yes, I misspoke COVID. So, CVID, not COVID, but I think the answer is the same. JTJ says, why not recommend a bolus dose of vitamin D3 on day 1 of COVID-19 as to raise the blood levels ASAP?
Yeah, so people have given very high doses of vitamin D3. The problem with vitamin D3 is it has to be activated. So you're giving cholecalciferol, needs to be hydroxylated to the 25 hydroxy vitamin. So that takes time. It takes about 2 weeks to be fully hydroxylated. In addition, the absorption is a lot less. So, you could give it IV, but it has to be metabolized to the more active form. So that's why we recommend in an outpatient setting to take regular D3. And I think the benefits of vitamin C are taken up front. Once you patients are hospitalized, I think it becomes less efficient. And once you're admitted to the ICU, I think the benefits are least. So we would recommend D3 in outpatients. In patients admitted to hospital, I think you need to take the activated form because it takes time for the D3 to be hydroxylated.
Got it. Thank you. So here is a comment, FLCCC for the Nobel Prize. So thank you for your work. We love you. So this is so here is another question. Doug Poss, Dr. Bean recommends taking ivermectin with food. So I usually say that with food is fine. Your comment, without.
So actually, it's a good question. It appears that your blood levels are much higher when you take it with food. So although it says take on an empty stomach, we would recommend taking it with food. It seems to be much more better absorption.
One more question, and we would take another few questions. Melanie Goodman says, is ivermectin safe for the kidneys, people in kidney failure?
Absolutely. Okay. Yes, absolutely. Yes. Normally less than 1% is excreted by the kidney. So it's absolutely safe in patients with kidney disease.
And I guess the answer here would be yes as well. Laura's question is it okay for chronic kidney disease?
Yes, absolutely, for the same reason. Yes.
Let's see. Jana says, good to take with dinner. Quercetin and ivermectin interaction.
Yes, it's possible, but we don't think there's a major interaction. So I think it's pretty safe.
Excellent. So Arbor, there is a question about the bromhexine, and I am deliberately trimming those questions that are not directly related to ivermectin, and that is why I'm not doing it. It's just that I want to keep it focused. Colin says, I even lied to my doctor and still couldn't get it after saying I had threadworms.
Yeah, I think you have to tell him you got really bad scabies.
Cool. So one more question, and then Denise says, I'm also a long hauler, and doctor has prescribed biological monoclonal antibodies, Dupixent, and my pharmacist did a drug-drug cross interaction with Ivermectin for me. Okay, so Denise, did they not give it to you, or did they said that is fine? So one more question, and then here. So AJ, can ivermectin cause migraines?
So, any drug can cause any side effect. I would imagine that it would be most unusual as a specific side effect. I mean, people have reported mild headaches, but I think it would be unusual.
Jody says, why is NIH not recommending ivermectin? I think you discussed a bit of that. So further comments?
Yeah, I think it's a mystery to me.
Yeah, Jody, if you listen to a little bit of this video earlier, Dr. Marik went into that detail as well. It's unfortunate, actually, that they're doing it. Cool. So last question, and then we break for today. Just promise me one thing. You would like and share this one. If you like it, don't do anything else, then YouTube automatically starts sharing it. But if you share it as well, that also helps. I think the information in here, I'm not being clickbaity or salesy with you. I think that the information in here can be useful, not only for healthcare workers, but for general public as well. One more question. This is interesting. So for intubated COVID patients with mechanical ventilation and therefore not being able to give ivermectin orally, how would you administer ivermectin?
Yeah, so this question has come up before, and you can crush the tablet and give it through an OG or a nasogastric tube.
Got it.
It's not available intravenously or intramuscular, but it can be given orally. Dr. Raja in Florida, had a lot of intubated patients which he treated with oral ivermectin.
Excellent. So, Dr. Marik, thank you very much. Thank you for staying up once again late. I know it is now beyond past 8 o'clock. Thank you very much. Thank you for being a king bean. Thank you for being here with the cool beans. Thank you for all of your work. Thank you for saving people. Thank you for going and talking with NIH. Thank you for Dr. Corey to go and talk in Senate as well. Thank you for all of your effort.
And we must thank you for everything that you do, because you help us spread the word, and that's we need to inform the public. We need to inform doctors, because I think that's how we can effect change. And for that, we thank you.
Thank you very much. So Cool Beans, thank you very much for your time, for your questions, and for interacting with Dr. Paul Marik. I know that we all love him so much that he should just be here with us every day, but that's something just our dreams. So thank you. And I'm going to go offline. Please like, subscribe, and share. Please share for sure if you can this one. Bye-bye.